Hi everybody, I'm Jennifer Blevin-Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today I want to do another addition to the new billing sequence that I started, and today will be a little bit shorter than the last two videos, but I wanted to go into a little bit more detail about the specifics that I am finding with claims coming back and issues I'm running into that need to be fixed. I'm hoping that by bringing these up, it will help you avoid some of these or things to look for as well when you're getting claims back, to be able to put processes and check and balances into place to avoid them moving forward. The number one thing I am finding the most is that there are patients that we are seeing who require a referral on file in order to be seen at our practice. Now, this is a little bit of a unique situation for us, but it might not be for you if you're a specialist, or depending on what area you are in and what the payers in your area require. But we are serving patients in a capacity of an immediate care, acute care walk-in clinic, and kind of like an urgent care, but our taxonomy code at the payers and under our MPI is family medicine. So when a patient has an HMO or they're on a specific plan that requires a referral from their primary care and we don't have one on file, then they're denying the claim. Now, luckily, we're hoping that these plans will approve a retro referral and we will be able to resubmit those claims and they will be covered, because we are seeing the majority of our patients for COVID and COVID treatment. We have been allotted, thankfully, monoclonal antibodies, and we're able to treat people same day, where a lot of the other providers in our area either don't have monoclonals or they don't have enough to be able to treat all their patients, and some of them are even referring to our office knowing that we have the capability to treat patients same day or the next day, and we have enough to be able to do that. We're very fortunate, and so we're hoping we can use that leverage to get a lot of this approved. So when I see these come over and I see that a referral is required, what I am doing is, one, I'm putting a pop-up in patients' charts so that anytime a staff member, especially front desk, goes to schedule the patient, it pops up stating that the patient cannot be seen at our practice without a referral on file, or they will have to pay cash at time of service. We would need to notify these patients before they have services rendered, letting them know about this so that we can charge them, but we want to leave it up to them if they want to do so. Now, given the nature of how we see patients and the need that they come in for acute care of not feeling well or a pain or an injury, that definitely puts a little bit of a spin on things, because waiting for a referral could take quite a while, especially depending on how busy the PCP office is in getting that done and sent over to us, and then us contacting the patient. That's why we like to give them that information up front and let them decide. A lot of payers in your contracts will allow you to collect from patients at time of service for those kinds of situations, as long as you are able to inform them up front before services are rendered that their service may not be covered at our office, or it's not a covered service, and then we can collect cash for that. The other thing that I'm seeing are Medicaid patients will tell our front desk that they have either straight Medicaid through the state or they have a CCO plan, and it's one or the other. Most likely I'm seeing us billing straight Oregon Medicaid, and it comes back saying that the patient is on a CCO plan. In that situation, I log into the portals, I go and check, and sure enough, they have the local CCO plan instead of straight Medicaid. Again, I'm putting pop-ups in there, letting patients know that on the chance that it's a CCO plan that is outside of our county, because in Oregon, a lot of our CCO plans are given to patients based on which county they live, and we are just right on the border of a few counties, or we have people coming from local counties for those COVID treatments, like from a half an hour away, and they're being seen, but it's not covered because we're not contracted with that CCO plan. We're only contracted with the one in our county. In that situation, I'm applying for prior authorizations and I'm trying to get it, but they're denying it because we're not contracted, and they say that there's other people in their county that offers the same services. Unfortunately, I can't bill patients after that because that's breaking our Medicaid rules and laws in our contract. So we have to eat that cost, which is very unfortunate. So I'm making sure I'm putting pop-ups in those patients' charts as well, letting those patients know that if they schedule again, they will have to pay out of pocket because we're not contracted with their specific Medicaid plan. And if we can tell them up front that it won't be covered, again, they can pay at time of service as long as we notify them before services are rendered. I have been working with the local counties, neighboring counties plans, and they have agreed to allow us to become contracted, which I'm very excited about, as long as we see patients for acute care needs as we have been, and not going to see them as primary care and follow them for chronic conditions, which is totally fine because that's not what we want to do. And this should eliminate a lot of problems, but in the meantime, I'm having to train my staff on making sure that they're checking appropriate portals that they have access to see if patients truly do have Medicaid through the state or if they are covered by a CCO plan. So this definitely goes back to training and informing and teaching my front desk staff on checking those things before we see patients, so that we can educate the patient and let them know if it will be covered or not and what the cost would be upfront if they paid out of pocket. So we've covered the referrals, we've covered the Medicaid issue. The other thing is Medicare. So a lot of patients get confused when it comes to Medicare, and I totally understand because it is confusing for us who have worked in healthcare forever. And a lot of patients either don't realize that their Medicare is covered through an Advantage plan and then we don't bill Medicare, or they have a supplemental that they have to give us that information as well. And the nice thing about the supplementals is Medicare will automatically forward the claims to the supplemental if they have it on file. But when it comes back and we get a payment from the supplemental for a patient that we didn't have on file, they had a supplemental, we have to call the patient, track it down, and get that information added. The nice thing is it doesn't affect the cash flow, but we definitely need that information in our system. But when we bill straight Medicare because a patient forgot they have an Advantage plan, or they didn't realize that their Advantage plan is actually their only way of billing, it's in place of their Medicare Part B, that's where things get confused. And my front desk staff work really hard and they've done a great job learning, but they're still very green, and so they don't understand that if they get handed an Advantage card, an HMO card, that it's a Part C plan, and we don't have to necessarily enter the Medicare as a billing insurance, but we just enter it as an informational insurance in there. In our EHR, we can enter insurances that we don't tag as primary, secondary, or tertiary, but just have it on file, and that's what I ask my staff to do. It's always good, no matter if a patient has a Part C plan or they only have Medicare as Part A, to still scan in their Medicare red, white, and blue cards and put that information on file in case we need it in the future. And it has come in handy because a lot of the Advantage plans are coming back with claims covering everything but the monoclonal antibody code, and say that we have to bill Medicare directly for that code specifically. And I think it's because of the money that has been granted from Congress to cover specifically this, and it's not coming out of those Part C plan businesses like HealthNet, Regents, and AARP UHC, but it's definitely coming out of the Medicare budget. So it's good that we have that, because that's the first time I've ever seen that if someone has an Advantage plan that we have to bill something separately to Medicare. And I know it's because of the pandemic, but it's not something we were aware of before. It's not until I've been reviewing claims and seeing the codes on the claims stating that we need to bill that code specifically to Medicare. The last thing is the inactive insurances, and honestly my staff has done an amazing job of weeding those out, and so I'm not getting a lot of those, but I'm definitely getting enough, and so that does make me want to go back to my staff and remind them they need to be checking eligibility when patients schedule, and then once they come in, and making sure that if it is inactive that we're collecting the correct insurance, because it just delays payments and that comes out of your pocketbook. It's never a good situation. So again, I can use this as a learning tool and an example of why we do what we do up front before sending out claims. Because remember, the revenue cycle really starts at the front desk when you register patients, schedule patients, because they need to be checking eligibility, they need to be checking benefits, and having those cost share and coverage conversations with patients at that time. So those are the biggest things that I've been seeing. Keep your eye out for those. The plans that require referrals depending on your specialty, the Medicaid situation, the Medicare situation, and the inactive insurances. Hit the thumbs up today if you learned something new, or if this was helpful. Please leave any comments that you would like for me, and any video ideas that you would like me to do. And subscribe to my channel if you haven't already. I appreciate the support. Have a lovely day and stay healthy. Bye-bye.